Hello and welcome to the Frontline to Finish Line podcast, your go-to sport and exercise medicine podcast series. I'm Claire Spear, a specialist MSK and aquatic physiotherapist.
And I'm Dr Ed Appleby, a sport and exercise medicine specialty trainee working across MSK services and elite sports team in the Northwest.
Together, across this series, we'll be speaking to a number of industry-leading experts, exploring some fascinating topics across the multidisciplinary world of sport and exercise medicine.
We're delighted to have you join us, and we hope you enjoy the listen. Welcome to today's podcast. We are delighted to be joined by Dr Ross Hemingway today, who's going to talk to us about exertional heat illness. Now, we're coming to the end of the sort of autumn marathon season, but I'm sure there's still lots of reason to be talking about exertional heat illness, as Ross will explain to us in the podcast. And obviously this will be posted for anyone to go back to in future when we're coming back round to the summer months. So Dr Ross Hemingway is a sport and exercise medicine GP in the Commando Training Centre for Royal Marines. He has extensive experience in managing amateur, elite and tactical athletes with exertional collapse. He's a national expert in the prevention, acute management and rehabilitation of patients with exertional heat illness. He's passionate about reducing the morbidity and mortality associated with EHI. He's a founding member of the UK Heat Illness Advisory Group and is an author of the UK National Consensus Faculty Pre-Hospital Care Guidance on EHI. Ross is also an honorary senior lecturer in sports medicine at Exeter University and matchday doctor for the Gallagher Premiership Rugby and Rugby Football Union. And finally, and well-deservedly, Ross was awarded the OBE and the 2023 King's Honours List for services to the Royal Marines. So without further ado, I'd like to introduce Ross Hemingway, and I'll open with a question to you, Ross. What piqued your interest in exertional heat illness and how did you become an expert in this area?
Thank you very much for that kind introduction. And before I answer that question, I'd just like to say thank you for inviting me on this podcast. It's an honour and a real pleasure to be invited and to discuss exertional heat illness. So, yeah, what piqued my interest in exertional heat illness? Probably it goes back to my early career as a Royal Naval Medical Officer, which I spent most of the time with the Royal Marines, and this was in sort of hot environments across the globe. And I clearly had a few patients who suffered exertional heat illness, and we didn't really get taught much about it at medical school. And to begin with, I just found it fascinating. There was lots of unknowns, and it was a disease that you could treat quite quickly and effectively and see the results of it. And then interestingly, probably about 15 years ago, on one of the operations, we were out during the middle of the day, and temperatures were between 40 and 45 degrees, and I actually had mild exertional heat illness myself, which was a really awful feeling. Fortunately, I didn't collapse, and I made it onto the helo and onto the helicopter, but I had narrowing vision. I felt awful. I was nearly sick, and I actually didn't tell anyone about it because I was quite embarrassed. And the last thing you want is for the doctor to go down and suffer exertional heat illness when you're meant to be looking after troops. And yeah, interestingly, actually, on that, we had one of the military working dogs, and they unfortunately did suffer from exertional heat illness during that operation as well. We had to cool the dog down as well, but they were fortunately fine and made a full recovery. So yeah, it's not just humans; it's other mammals as well. So yeah, that's what piqued my interest, and then working at the Commando Training Centre, it's as you would imagine, it's arduous training and it's difficult, and we exertional heat illness is inevitable, and therefore almost out of necessity, I had to just understand it more to effectively treat recruits and young officers and trainees, and then after that initial acute treatment, so that subacute treatment, and then return to sport, return to play, return to training, and then it's sort of you work with other people across the UK, both military and civilian, and hence that's where I sort of end up on the podcast today. So thank you.
Thank you so much for joining us and bringing that expertise and being happy to share that as well. Because I think that making people aware of this is something that's important. We kind of probably don't understand enough about it as healthcare professionals. I'm hoping I'm going to change that by the end of the podcast. So how do you define exertional heat illness? What does that mean as a term?
Yeah, it's a really good question, and it, my mind goes back to when we formed the Heat Illness Advisory Group. So a group of about 10 clinicians across the UK from really varied backgrounds, some brilliant colleagues. I won't go through all the names now because I'll probably forget one of them, but they know who they are, and a wide variety of specialities from sports and exercise medicines to anaesthetics and intensive care and pre-hospital emergency medicine and general practice, etc. And we needed to define exertional heat illness, and it took us about 2 weeks of communications and emails and discussions, and before we came to a consensus, because there's lots of definitions out there, and it's really confusing. If we look at ICD-11, which is classified the effects of heat, we have heat stroke, we have heat syncope, there's heat exhaustion due to fluid depletion, heat fatigue, brackets transient, I think, effects of heat unspecified is another one. So it's just really confusing. And what we did agree on was that it's a syndrome, and it's obviously associated with a raised core temperature and disordered thermoregulation, and that it occurs on a spectrum of severity. And it obviously has to occur during or immediately after physical activity. And so we have exertional, but we need to bear in mind that there's also non-exertional as well. And that actually is the vast majority from a public health perspective. Much more people suffer from non-exertional, also known as classic heat illness, than they do from exertional. And those populations are those who probably have impairment of thermoregulation from the beginning, and that those populations are those at the extremes of age, those with comorbidities, chronic disease, polypharmacy, and it occurs not during physical activity. And then we have the exertional heat illness, which classically occurs in sporting populations, and that's from amateur athletes right through to elite athletes, and then in there in the military as well. And then you've got this cohort who are in between. So they're usually occupational based, and they may be doing some kind of physical activity, but that's intermittent. They may be wearing PPE. They may be sat there being exposed to high environmental temperatures, and that's your construction workers and emergency medical services workers, farmers, and a lot of the time they're also wearing PPE. So they're a really interesting population. So yeah, we agreed on what heat illness, what you need, what was needed, and what was in heat illness, but the definitions and current definitions across the globe have tended to use exertional heat exhaustion and exertional heat stroke, and that can be really confusing because if you look at exertional heat exhaustion, patients don't tend to just have exhaustion; they have other signs and symptoms as well. And exertional heat stroke, well, it's not a stroke; it's more an encephalopathy. So we agreed that to make it straightforward and relatively sort of simple to treat in the pre-hospital environment, we would just go for mild and severe. A bit like the sort of big sick, little sick that you learn in pre-hospital medicine. So the mild would be, and this is the definition that we agreed upon in the end, was a core temperature which is typically between 38.5 and 40 degrees C, with signs and symptoms of exertional heat illness, which I can explain later. But key is no central nervous system dysfunction, and it clearly had to occur during, immediately after physical activity and exercise. And then severe exertional heat illness, also known as heat stroke, especially in America. The key to that is it's a life-threatening condition. It encompasses disordered thermoregulation, and you have central nervous system dysfunction, i.e. decreased GCS, or in the pre-hospital environment, decreased ACVPU. And that, again, occurs immediately during or after physical activity. And so, they're the definitions that were published in the consensus statement.
Brilliant. Thanks, Ross. I think when I was revising for my faculty exams, it was more complicated, and that seems to have simplified it really nicely. We'll go through the signs and symptoms that you look for with those definitions in a minute. But I actually just wanted to ask about what the risk factors are for EHI, sort of both intrinsic within the person themselves and environmentally.
Yeah. So risk factors, we're beginning to learn more. What we don't realize is the risk factors themselves, how much they increase the risk independently or as a whole. So you can group it in different ways. You can have it intrinsic and extrinsic, or I quite like the lifestyle, health and work, and you see that sometimes. So your lifestyle will be those who potentially are overweight, poor physical fitness, smokers or vapors, alcohol, illicit drugs. Health, key risk factor is previous exertional heat illness. We definitely know that. And then mild illness, and mild illness, and I'm thinking of mild upper respiratory tract infections, gastroenteritis, or mild skin infections. Recent vaccinations within 48, 72 hours has possibly increases the risk, and you can see why that would occur, especially if it's associated with a fever, and sunburn increases is a risk, and then other medications, antihistamines, non-steroidal anti-inflammatory drugs, and being hypohydrated. And then if we look at the work, I think key for sport really is an interesting one. Is those individuals, those athletes who are younger, maybe on pathways in academies, so less experienced individuals, and we definitely see that within the military population. Those going through recruit training as an initial training, so the inexperienced, and maybe that's a behavioural thing that they don't want to, they're not educated, they don't know the signs and symptoms, or actually they have them but don't want to report them to their coaches or medical team. And then what else is there? You look at them to the sleep, disordered sleep, stress, air travel, so teams flying over international time zones, and then in that it's almost just your obvious nutritional issues, and then unacclimatized individuals, and that's absolutely key. So it's absolutely key is pre an event that the individual to reduce their risk acclimatization, and we know that in sports. But I just go back to one of the biggest ones here, and that is probably comes under lifestyle, and that is motivation. And motivation is a really, really interesting one, and that's whether you're the athlete is an amateur athlete, say for example somebody who is for the first time running a marathon, half marathon, 10K, and they're running it for charity, and they've got deep emotional connection with that charity. they have to finish to raise the funds, otherwise it would be seen as a failure, not in their mind, but maybe not the people who are sponsoring them, and they will run themselves into the ground to try and finish. And then as we go along that pathway, we have our amateur athletes, so your weekend warriors, as it were, who almost sub-elite sometimes, and they are aiming for their, and I'm thinking of a marathon here because it's usually associated with endurance events, triathlons, Ironmans, marathons. They're aiming for a PB. They have to beat that 3-hour mark. They have to. This is their 6th marathon, and they are determined to get below 3 hours 30, etc. So, if lots of people listening to this podcast will have worked in marathons and know exactly when that peak comes in, and the peak comes, when I say comes into the medical tents, and it is you can almost set your clock by it when you start hitting that almost 3-hour mark or up until the 5-hour mark, and then after that, almost the pace is slow for a marathon. The pace is so slow that they're able to sort of, they're not creating enough heat, but you do get them sort of 5 hours plus. And then your marathon runners, you don't usually see exertional heat illness in the elites unless the environmental conditions are so extreme that even the best in the world are almost, sort of, there's no way out of it, and a large percentage of that the participants will either pull out before they get exertional heat illness or have exertional heat illness. And there's been a few races over the past years where that has obviously occurred. And then the second key one is just acclimatization. And you got to, in the military we say, you got to sort of train how you fight, as it were. So if you're going to go and do an event or whatever sport it is, you need to be training in the conditions that you're going to be racing at, etc. So they're risk factors. Lots of work needs to be done still. It's a lot of it is anecdotal, retrospective evidence. Other risk factors that are coming to sort of that I'm noticing really is maybe snus and vaping. So tobacco, does that cause some kind of inflammatory response, and that primes the individual to increase risk of exertional things? I don't know. And interestingly, we've just done Professor Walsh, marvelous man from Liverpool, John Moores University. He down at Commando Training Centre, him and his team, and I was sort of delighted to sort of be a part of that team. We studied at we had 800 recruits who went through a high risk serial, as in high risk of exertional heat illness. It's something called a 6-mile speed march. So it's a forced pace, 21 pounds in a weapon, wearing some kind of PPE, and we know that the risk of exertional heat illness is increasing that serial, and 800 recruits went through it over 2 or 3 years, and they swallowed a core temperature pill, and we measured inflammatory markers and infection markers pre and post, and the papers are due to be published shortly, but preliminary data shows that those with an upper respiratory tract infection are 3 to 4 times more likely to suffer from an episode of exertional heat illness, which is probably the first time that a prospective trial has ever been done, which is incredible in 2025, isn't it? A prospective trial has ever been done on risk factors and exertional heat illness. So, yeah, we've got a long way to go to fully understand risk factors, but they're the sort of common ones.
Fantastic. And just thinking about, I suppose, the extrinsic factors. Again, there's probably not studies to back this up, but just in your opinion, do you think it's becoming more frequent? We're just better at recognizing it. I'm thinking about maybe the increase in people wanting to do ultramarathons. You know, the Marathon des Sables is now something that people have on their bucket list and are quite happy to go off and do as a, you know, an event that they have to tick off. And I suppose the other thing, thinking about being kind of global warming and the change of the temperature of the earth into that, you know, thinking about those springtime marathons that everybody's spent the whole winter training in cold, freezing, dark conditions, and then suddenly you hit London and it's a 35-degree marathon day. Those kind of things, do you think that's having an impact, or do you think we're just better at recognising it?
Yeah, good question. I'll give the political answer. Probably a bit of both. So yeah, I think we are definitely, and the medical community, the sports medicine community, we're definitely improving our ability to recognise exertional heat illness. Absolutely, and responding to it when we do have athletes with exertional heat illness. So yeah, education and that recognition is definitely improved, and probably just the recognition that it's not just a benign illness which will settle down if you just cool somebody down without consequence. And we do realise that it can be life-threatening, absolutely. And that was one of the purposes of the consensus statement, I suppose. So yeah, I think we are recognising it, but you're absolutely right. Climate change, altered weather patterns, whether that's in temperate or tropical climes, is definitely going to have an impact. And we know that in I mean, the London Marathon is a good example, isn't it? If you're training during a UK winter in temperatures on average between 5 and 15 degrees, and then as we come into spring and the marathon sort of end of April, then we may hit mid-20s, and people just haven't been trained that, so that they're not acclimatized. So that's a good example where that might increase the risk of exertional heat illness if individuals have been training in lower temperatures. And then in tropical climates, if we're seeing not just tropical as well. If you look around the Mediterranean in summer, in Spain and France and Italy and Greece, the temperatures over the past 10 or 15 years have clearly increased. And who would have thought that even in the UK we would have had temperatures hitting 40, like we did back in 23, I think it was, 22, 23. We would have never thought that 10, 15 years ago. So yeah, climate change can only increase the risk of exertional heat illness. And then you mentioned something as well. Not only are just mass participation events more popular, people are doing crazier and crazier things, aren't they? I went to Tenerife and this person wants to go to Levenerife. Like it's just, I remember seeing someone a few weeks ago, and they for a risk assessment, and they were going to be doing a Decker Ironman or something like that, like 10 back-to-back Ironmans. And so I think more people are doing events, and some events are just going to be probably have increased risk, and it's this bit of a numbers game, isn't it, as well. So yeah, I think we will see, and we are seeing more exertional heat illness. So many factors why.
And actually, Ross, just I guess while we're on that, have you got any practical tips for those weekend warriors for, if you are trying to acclimatise for something like a spring marathon while the weather's cold over here? Is there anything practically that you've seen used for your sort of military colleagues, or is it just you've got to, like you said, train like you play?
Yeah. So I think you can do, and there's some there's some good papers on there on acclimation. If we think back to COVID, when our elite athletes weren't able to travel and go to hot climates to acclimatize, then there's some great sort of on social media sort of Heath Robinson contraptions of people putting heaters in sheds and along with an exercise bike and ramping up the temperature so it's like a sauna, etc. So yeah, you can sort of acclimate. So in the UK, whether that's during the exercise, going into your shed and put an exercise bike and then ramping up the temperature and stuff. But that may, you don't want to get heat illness doing that. And then there's the baths, 40-degree baths for half an hour or saunas after exercise. So yeah, that is achievable. And lots of elite athletes did it, especially during COVID. When they couldn't travel, and they do it in the UK as well when fixtures and their diaries and events don't allow them to go and acclimatise in hotter environments. There's a huge caution to that, isn't there? I do remember when I was working up in Leeds with the air ambulance up there, and I was out in the on the car, and someone was wearing wrapped themselves in a load of bin bags and gone for a run and collapsed with heat stroke on the street. Yeah, so yeah, it's not without its risks. But there are methods, but I think would I be advising them to the general public? Well, I don't know. It's quite a worrying one. But then again, I think with technology, that can be very, very useful. And there's quite a few devices out there now which are starting to use mass data, AI, using physiological monitoring, whether that's a specific hardware in itself or using your Garmin watch or iPhone and measuring HRV and using algorithms to estimate your core temperature. So I think watch this space. It's occurring already, isn't it? And I think that's probably in the future that's how people will maybe prepare themselves for events, whether that's in the UK or in warmer environments.
So for those people that maybe can't acclimatise or haven't acclimatised, and unfortunately we end up seeing them in the medical tents or wherever they may appear, what signs and symptoms are you looking for? What are you most worried to see? How would you assess in the field?
So as I mentioned before, it's a spectrum of disease from mild to severe, and common signs and symptoms, we'll start with mild, really. So I think one of the first questions that I ask somebody who is suffering from or suffered from exertional injuries, do you feel or did you feel uncomfortably, horribly hot? And they will inevitably say yes. And now they also commonly complain of headache, excess fatigue is common. And that in may show in elite athletes, whatever sport, as maybe poor performance and dizziness. And then as we sort of go down that spectrum, and not everyone follows, not everybody has the same signs and symptoms, but other signs and symptoms: tunnel vision, nausea, vomiting, just unable to continue the exercise that they're doing, so haven't necessarily collapsed, but unable to continue. And they're sort of common mild symptoms, or what we would also know as exertional heat exhaustion. And then severe heat illness, as I mentioned before, the key is that central nervous system dysfunction, and that might be quite subtle to begin with. And might be challenging to pick up, but confusion, behavioural changes, and agitation. So it's not uncommon for people to be quite agitated. They're scared. One of my great colleagues, Colonel Mike Stacey, he says they've got brain not working syndrome, and I quite like that. Quite simple, and they don't. They're scared. They don't know what's happening. They're disorientated, and they may actually become quite aggressive. And I've seen colleagues who've been punched, who've been bitten by those with severe heat illness. Commonly known as exertional heat stroke. Other signs and symptoms, so that ataxia, that stumbling gait, and we've all seen Brownlee in the triathlon, and I think it was the Mexico triathlon, wasn't it? So that's a classic example of ataxia, and then they collapse, they can have seizures, fecal incontinence is common, cardiac arrhythmias are very common, and then can go into coma. So they can be really, really poorly.
Brilliant, thanks, Ross. And so now you've got the patient into the medical tent, you're suspecting EHI. What would your initial assessments be in that environment?
So I think as with any acutely unwell patient, you've got to follow the A2E assessment, and in that A2E assessment, if you are suspecting exertional heat illness, then a core temperature is required, and this can be done a couple of ways: esophageal, which is uncommon, or erectile temperature, and that's key. It really is. And one of the recommendations, recommendation 7 of the consensus, we clearly said that tympanic or infrared are not recommended. They risk inaccurate readings and a false sense of reassurance, either in the diagnosis or during the treatment. So a core temperature is required for those with exertional heat illness. But I think at the same time, it's really important to think about other causes of exertional collapse, and common ones. Hypoglycemia is common, and DEFG, don't ever forget glucose. So that's part of your A2E assessment and should never be forgotten, and clearly more common in endurance events than other sports, but it is common, and obviously, and sometimes you see it in those with exertional heat illness as well. And is that because they're in sort of this hyper catabolic state, or have they just been doing a lot of endurance activity, and they go together. So hyperglycemia, don't ever forget that. Cardiac, don't ever forget cardiac causes. Majority, if not all, elite athletes will have cardiac screening, but in mass participation events, amateur athletes won't. So they may have an associated cardiac pathology, which has been may have contributed to the exertional heat illness. They don't have to have necessarily collapsed due to an arrhythmia. So you can pick up arrhythmias such as pre-entry tachycardia, as Wolff-Parkinson-White, or other significant cardiac pathologies such as HCM and ARVC, etc. So, don't forget the cardiac, exercise-associated hyponatremia, waterlogging, overhydration. Don't usually see this in elite athletes or events that are shorter than 4 hours. It is more the ultra endurance events, and then the ISTAT or point of care testing is really, really useful to rule out an exercise associated hyponatremia. what else? ECAST, so exertional collapse associated with sickle cell trait, is something to be aware of. Mostly athletes will be screened for that, but clearly general public may not be. And then just your other causes, your other medical causes. People can have subarachnoid hemorrhages, PEs, strokes. So yeah, we should not forget those. Other causes. So yeah, so the whole A2 assessment, core temperature, absolutely key. Using rectal, and just on the rectal, I think we really need to. It's difficult, isn't it? And we do accept, and we wrote it in the consensus that not everybody will have access to be able to do a core temperature, rectal temperature, but I think we do, if we do need to ensure events, if there is a high risk of exertional heat illness or increased risk of exertional heat illness, then that capability should really, in my mind, be there. But we understand it's not always, and especially at the small events, smaller events, it just may not be. And just a word of warning on the rectal temperatures. I think we need to be careful that the solid metal ones are, that there is a risk of perforation of tissue there. So we wouldn't recommend them. I wouldn't recommend them, and I am aware of a case where there has been a sort of tissue damage to the rectum from one of those probes. So yeah, a flexible thermistor is the preferred method for measuring core temperature.
Really, really important message. And I guess then, anyone listening to this podcast who covers events, it's a consideration that if you're going to be medic there, you should really try and make sure you've got on your kit. It's not always easy, but
no.
Fantastic. So you've diagnosed somebody at, let's say, I'm thinking about when I've volunteered and done medical stuff at the marathon. You're in your tent, mile 18, kind of, you've got your probe, you've decided this person has got exertional heat illness. What would immediate management be, and what would you do? And I guess that would be different depending on where the spectrum they are, but if you could talk us through kind of maybe the mild and the severe.
Yeah, sure. So I think with regards to mild, the mild and severe, the key is recognition, isn't it? So that starts beforehand with education, and then when you're there, I think we just need to be aware of it in those individuals who are sat there quiet, looking exhausted, quite fatigued, and maybe with a sort of relatives and just resting, but actually they have heat illness and no one's really sort of recognized it. So recognition is key, and even at elite events, I'm just laughing. When I do a lecture, I sometimes show the slide of the Paris 2024 men's triathlon and the finish line, and it was absolute carnage. And there's athletes vomiting, they're collapsed, and the commentators are saying blamed the River Seine for pollution in the River Seine, and that they for the vomiting, etc. So yeah, we got a long way to come. It was a really, really hot day. It was humid, and they clearly had exertional heat, and I'm absolutely certain of that. But so recognition is key. So yeah, think about the other causes. Try and get a core temperature. But if you don't have a core temperature, then if you suspect exertional heat illness, then cooling is rapid cooling at scene is the key. So for mild, what we recommended in the consensus was that we use shade strip spray and fan. It's quite difficult to say, is that S3F? Shade strip, spray and fan. And that can be really effective. It will clearly take longer than other methods, but what we wanted was to ensure sort of simplification, and people weren't confused on how to manage exertional heat illness. So placing them away, take them out of the sun, stripping them down to sort of light running clothes or their underwear, spraying them completely with water, and then a fan, and a big industrial fan is clearly going to be more effective than a smaller one, and the handheld fans, etc., are just useless. But you know, if you don't have that, then it's a piece of cardboard, and it's a bit of elbow grease in there, and it's difficult, but it will work, and it will cool people down. In the US, they are quite keen on the whole rotating towels. So a bucket of ice water, rotating towels every 30 to 90 seconds. And there's a few issues with that. Number one is, if you got loads of water and loads of ice, well, maybe cold water immerse them instead, because that's going to be more effective. It floods everywhere. And your resource manager will be unhappy with you, and also it's really difficult just to rotate every 30 to 60 seconds, and that doesn't occur, and people usually end up having the towels on them for minutes, and that decreases the effectiveness. There's some other products which use conductive heat transfer. There's no evidence for those. And I personally wouldn't recommend any of those. And you know, some companies are sort of pushing quite hard on the market to use those, but there's no evidence to say they're effective. And then, if somebody has severe exertional heat illness, i.e., exertional heat stroke, the key here is that the analogy is a bit like the management. It's a time critical illness, so the analogy is very similar to those with an MI, who had an MI and a stroke, and time is tissue. So we've got to cool first, transport second, and that's the sort of, as the Americans say, you know, that's the paradigm change, or cool first, cool fast. And the gold standard of that is cold water immersion, and this is supported across the globe, but multinational organizations, internationally. So the American College of Sports Medicine and the International Olympic Committee, US military, UK military, and it's been used as an effective cooling modality for many years now, with excellent results and almost sort of zero mortality. It feels quite daunting to do at first. You've got this really sick patient, and you're sort of saying, right, okay, let's dunk them in a load of water and ice, and it just feels a bit odd. But animal models show that survival outcome from exertional heat illness is let me get this right, is inversely proportional to the time spent with an elevated core temperature, and it is relatively straightforward to do. Actually, you need some kind of cooling pod. You need a good amount of water, between 50 to 80 liters, and you don't necessarily need ice, but the ice is there just to reduce the temperature of water, and an optimum temperature for cooling really is of the water is between 5 and 10 degrees C. So 15 liters of ice is great for maybe 60, 70, 80 liters of water to cool it down, with tap water in most sort of in the UK, for example. So cold water immersion, and constant monitoring is key, just to monitor their core temperature, and I commonly get asked about cooling rates and what should we be aiming for, and the majority so there are sort of best practice in papers specifically from the US out there, and unfortunately they're done in laboratories with healthy young fit volunteers who've got a normal physiological hypothermia, and they're not agitated, they're not punching, they haven't got severe cramping, fecal incontinence, vomiting, etc. So I think in the real world it's much more difficult to achieve those temperatures of the cooling rate, but you can do, and I think a reasonable cooling rate of 0.1 to 0.2 degrees C per minute is achievable. Anything more than that can be achievable, but actually in the reality of the situation, just because it's so difficult with an acutely unwell patient, and getting anything more than that is quite challenging. And then we stop active cooling with cold water immersion when we get to 38.5 degrees. We continue that core temperature monitoring, probably for at least about 30 minutes, I would say. And we want to make sure the patient doesn't have a rebound hyperthermia or an overshoot hypothermia, which is a risk. And then once they're cooled, we need to think about transferring to hospital, which is another question I usually commonly get asked. I would suspect you're going to ask that as well.
Yes, that would have been the next question. So I guess there's two facets to this question. So obviously you've got the patient who's had severe, and you've cooled them, and sort of at what point are you transferring them to hospital? And then, are there any patients in which you are unsuccessful cooling at the scene and you have to transfer before the core temperatures come down? And if so, how might that look, that sort of transfer?
Yeah. Who do you transfer? So the consensus statement was we were quite clear this, and we did agree on this one, and it didn't take very long, unlike the definitions. And we did agree that anybody who has had exertional heat stroke, strong consideration, you need strong consideration to admit them to hospital. We really do, and that's for a number of reasons, and because if somebody has had severe heat illness, we know that there are increased risk of an acute kidney injury, acute liver injury, coagulopathy. We want to know what their ECG, make sure there's no underlying cardiac issues there. So yes, I think admission after to severe heat illness is definitely recommended, and especially those who have continued central nervous system dysfunction after cooling. We definitely want those individuals. Anyone who had a seizure, I would definitely recommend, or ongoing hemodynamic instability, I suppose, other comorbidities, those who have had prolonged core temperature elevation before cooling, possibly a high risk. And I think it depends on the level of capability within that medical tent as well, doesn't it? And capabilities differ across the pre-hospital. Capabilities differ across different sports and different events, because there are significant complications, rhabdomyolysis, high output heart failure, ARDS, cerebral edema. We mentioned acute kidney injury, acute liver injury, but that can progress to a multi-organ failure and acute kidney failure and liver failure, and there's many case reports out there of those who've had severe heat illness requiring organ support and because of organ damage. Yeah, so they're the people who definitely, if somebody's had mild exertional heat illness and no evidence of central nervous dysfunction and makes a full recovery within 30 minutes, then those patients need to be provided with advice and safety netting, but they don't necessarily need to go to hospital for follow up.
I guess again it depends on the setting, but if it's one of your Marines that's maybe been in that situation, how do you follow up with that athlete?
Yes. So after the initial acute episode, what I'm really interested in is almost two things. One is, was there a risk factor? Why did this individual develop exertional heat illness on that day? What is the risk factor? I'm always more concerned if I actually can't find a risk factor. So that's on day to day with the military population, but also when I have been sort of providing advice to team doctors with elite national squads as well across sports is okay. Why do you think that your individual has done this for numerous times? Why do you think they suffered exertional heat illness on that day? Because I do hear commonly that they've done this, and I just don't know why. And then you actually start plugging into it, and it might be when you dig deeper that there are risk factors that initially you're not aware of, and they may be can be varied across the field, or it might be that you don't find the risk factor, and they may have some kind of anything from I don't know, like an asymptomatic viral infection, which is causing some kind of systemic inflammation, which increases the risk of an episode of heat illness, but they're not showing any signs of symptoms to sort of behavioural, which we mentioned before. So risk factors is really key. And then in that subacute phase, what I want to know is their recovery, and one of the key things is blood tests. So if we do their blood tests on day 0, as in the day of collapse, we commonly see a raised creatinine. Now that doesn't necessarily mean that there's an acute kidney injury there. That might be just because they're not optimally hydrated. So you'd almost want to do 120 Unis creatinine 24 hours and look at their recovery when you've optimized their hydration. You commonly see their neutrophils and white cell count increased on day 0, which I've seen many patients then placed on IV antibiotics because their white cells 20 and neutrophils are up as well, and actually they haven't got an infection, and it's just an acute an acute phase response. And then I definitely want to look at their liver function tests on day 2, day 3, because we know that the ALT will start to rise. There's a bit of a lag, and the ALT can sort of peak around about day 2, day 3, and even continue rising. And we need to monitor that and we're looking for biochemical evidence of end organ damage there, which will affect when they can start their gradual return to sport and training. And those who had an episode of heat illness, what I actually find really useful is using a SCAT6. Now I know clearly that's for concussion, but it's a good symptom questionnaire, and you can tease out questions, and also just some other sort of maybe sort of symptoms, cognitive and balance issues. If you go back to what I said before, they've had brain not working syndrome. They've had a brain insult, and that can be just a useful tool to use before we have the the EHI6 or whatever we want to call it. But the SCAT6, is useful and can just pick up those subtle signs and symptoms of that have persisted because of their episode of heat illness. That's what I want to know when I'm following up individuals. And we don't recommend starting that rehabilitation, gradual return to play training before all the blood tests are normal. We need normalization of blood tests. We need their biochemistries and the majority. We need their signs and symptoms to have settled as well before we look at starting that rehabilitation process.
Do you use a similar process, like we do with concussion? They start to do some gentle exertion. If any symptoms reoccur, rest and reassessed and gradual periodization into it. Is that something that you recommend, or is it...
I do actually, yeah. And it's in my own practice, it's what I exactly do. And so if we look at the mild exertional heat illnesses, those individuals, we'll make sure there's no biochemical evidence of end organ damage, and then once I'm happy that they've got no persisting signs and symptoms, then a gradual return to training is what we do, and we monitor them throughout. It's interesting. There's just nothing out there, so hence that's why I said this SCAT6. I have created, just a questionnaire which was initially based on the SCAT6, and then just added some other questions which you commonly see post heat illness. I'm just thinking like muscle cramps, muscle pains, you make sure dark urine, and all these other things which are associated complications of EHI, and exactly the same. Yeah, so when they wake up in the morning, fill in the questionnaire. When they've done their period of rehabilitation exercise, did that trigger any signs and symptoms, and monitor them from there. And the majority of those who sustained an episode of mild exertional heat illness, they can be back to full training within a couple of weeks. Absolutely. Those who've had severe is quite different, and we do need to be cautious, because we know that those who have sustained an episode of severe heat illness there can be an increased risk of another episode, and within within sort of a short timeline. So what we don't want to is we don't want them to have another episode of heat illness, and we don't really understand those prognostic factors yet, and more research needs to be done on that. But within the military, we're quite cautious. So somebody who's had an episode of exertional heat illness, we will restrict them from activities for 2 to 3 months, and then at that 3-month point, we will then do a heat tolerance assessment test, which there's not many laboratories in the UK that do that, but I think I think if you've had an athlete who's had severe exertional heat illness, i.e. heat stroke, then I would be very cautious and would actually try and get some expert advice on it, to assist on that return, because it's clearly not a common condition, and it can be tricky, but we need to make sure that individual has fully recovered before exposing them to significant sort of risk and sort of race conditions or full return to sport.
That's really interesting. I'm really cycling back now, but the first couple of questions you mentioned kind of NSAIDs and antihistamines as potential risk factors. As a non-medic, I'm just really interested to know why that is. The medics probably know this one, but I'd love to know a little bit more about what it is about those particular medications, just briefly.
Yeah. So the upfront answer is we don't know.
Okay.
And it hasn't actually been proven, but there are studies out there again which are retrospective studies where there's potentially a link between these medications. So yeah, I don't know with the anti-inflammatories. Is it because anti-inflammatories can have an effect on kidneys, and we know that, and reduce the blood flow to the kidneys, so would that increase the risk of an acute kidney injury? But why would that increase the risk of a heat illness on the day? I don't know, and you'd almost think it's the opposite, because anti-inflammatories have dampened down inflammation, and we know heat illness more and more is due to some kind of disordered thermoregulation and an acute inflammatory response, not too dissimilar to SIRS. So systemic inflammatory response syndrome. So yeah, it's an interesting one. I don't know, and I don't think anyone knows really. And as I mentioned before, actually, a lot of these studies are pretty weak in the evidence chain, and we need more prospective studies to show if there's a risk.
It's really interesting, Ross. And this also hark back a little bit, all the way back to talking about the risk factors as well. Just thinking about the preventative measures that we can put in place for exertional heat illness. So both personal to the athlete and for people who are organising large-scale events, or medics who are looking after cohorts of either military or athletes.
Yeah. So prevention, God, is almost like a podcast in itself, is prevention. But from if you're managing athletes and want to, you have a squad, a team, and you want to advise them either collective or individually on prevention, where would I start? I think that first of all, it's just education, and education of the athletes, education of the strength and conditioning coaches, the sort of whole squad, as it were, and coaches. And that's actually what we do in the military, interestingly enough. So all military personnel have to do online learning on exertional heat illness, not just medics. And that's and I think that will be really useful across the board, and especially sort of coaches and strength and conditioning coaches, and because they're the ones working with individuals every single day, aren't they? And they know their athletes inside out, and will maybe able to pick up on the less obvious signs and symptoms of one of their athletes who's maybe suffering from exertional heat illness, but maybe doesn't know it themselves, or is potentially trying to, I say hide it, but yeah, doesn't want to hide it. They are hiding it, aren't they? They don't want their coaches to know, because they want to play in the next game, or they want to be picked for the next event, etc. And they don't want it to affect. And you can understand why. So I think that's really, really important. And so because spotting exertional heat illness early, and preventing it becoming a more severe episode is absolutely essential. As some of the American experts in EHI say, they say exertional heat stroke, because they all call it stroke in America, is predictable, but death from heat stroke is preventable. And I really like that message. Education, focusing on acclimatization, that's key. And you'll or acclimation in the UK. We talked about heat tents and the post-exercise immersion baths and so on, etc. Educating athletes individually on risk factors, over-the-counter medications, the importance of sleep and nutrition, and reporting mild viral infections. Pre-race, travel, nutrition, sleep, stress. We need to understand as a medical team that pre-event, pre-race athletes, especially big competitions, etc., they're going to be under a lot of stress, and does stress have an effect and increase the risk? Possibly. You can see how it would do. And then practical things on race day or pre-race. So preventative measures. The ice cooling vests are great. The Formula One now have these air cool convection jackets with a fan in them, and all silver and fancy and stuff. And I dread to think how much they cost. And but they may come on the market. But the ice vests actually really do work, and that is great, isn't it? Because a lot of athletes, before whatever event it is, will have to sort of hang around for quite a while, and that may be in exposed environmental areas where there's no shade or no air conditioning, and I do know that occurred in the 24 Olympics for some events, that athletes were actually just in the radiant sun and being exposed pre-race. So there's those human behavioural things that we can do, and then ice cooling is great. What else do people do? The ice slurries, whether they cool someone's temperature or just feel really good, who knows? But I'm sure it's better than a hot cup of tea, as it were. I'm trying to think of anything else really with prevention. I think that's it. I think that's covered the majority of it there.
So, Ross, are you saying that the warm cup of tea cooling you down is now a myth? I've always suspected it. I've always suspected that.
Yeah, I'm probably wrong, aren't I? And it causes vasodilation and to the skin, and it'll cool you down or something like that. But yeah, did you mention event organisers as well? I think you did, didn't you? So how what preventative measures event organisers can put in there, and that's a really that's again, it's not even a podcast in itself. It's almost a conference in itself. Is those pre-event risk assessments for medical directors of any event. It's a massive topic, and it's in the press, isn't it? It's in the public media. There's a little bit of conflict going on. Sort of the major sponsors, TV audiences versus the welfare of elite athletes, and I'm thinking timings, really, what time of day they're playing at, where they're playing at, and that goes across the board, not just in endurance events, but I'm thinking of tennis and football. Sort of in Qatar, a lot of the Football World Cup, a lot of the stadiums were air conditioned, and hence the rate and risk of exertional heat illness was low, because there was actually really cool in there, and that's not possible in all air conditioned stadiums for obvious reasons. Timings is a key one. Having events at midday instead of later on in the evening when it's a little bit cooler, and then event organisers can put in potential cooling methods, so like good strong industrial fans. The water sprays, I don't know if they cool people. I think they feel very nice, a little bit of spray in your face, but it's gone within seconds, isn't it? So it probably doesn't actually have an effect on your core body temperature. Staggered timings is another one, isn't it? Time of year, routes. So we do know that certain routes for races, if they go through built up urban areas, there's a lot of radiant reflection of energy, solar energy from the road or from the buildings on the individual. Which and then education for mass participation events is key, isn't it? Sort of there's a great app, which I'm sure lots of the listeners to this will be aware of, but there's an app called Race Ready. It's an amazing free app by one of my colleagues on the HIAG, Amy, and I would definitely recommend it, and it'd be great to see more. It's aimed at the non-elite athletes for mathematics patients to use it.
Sounds fantastic. And we will make sure there's a link to that and also to the consensus on the podcast, wherever you get your podcasts from. We'll link those to it. I've learned so much so far. I think there's just one thing that I'd like to, if we can keep you just for a few minutes longer, so I'm just fascinated. Where do you see the direction of travel going? Is there any kind of, you've talked a bit about research, but is there anything that you think is up and coming? You mentioned a little bit about AI and the wearables. Anything else that comes to mind?
Yeah. So yeah, I think it's really exciting. Actually, is the wearables. I think this will have a massive impact on reducing the risk of EHI and diagnose it, detecting it early, and preventing those individuals who may be suffering from early eye, then going on to develop severe EHI. So there's quite there's several things going on in research for that. There's the US have a device called the OBAN, Open Body Architecture Network. Anyway, it uses a really clever algorithm called EC-temp algorithm, and that measures the device measures skin temperature, heart rate, and has an accelerometer in it, and then is able to almost predict exertional heat illness in that individual. So that's really interesting. Other areas, well, I think one of the problems that we have in exertional heat illness at the moment is there's just a huge lack of high level evidence studies, robust studies, and that's across the entire spectrum of heat illness, whether that's prevention, detection, diagnosis, prognosis, risk factors. So I think we're going to see more and more research in these areas. I think that's quite exciting. Specifically, what would I look at? What am I interested in? I think we do need to understand more of the modifiable risk factors to improve prevention across the board, not only elite athletes. There's a huge lack of prognostication and return to sport, so they're sort of key areas that I'm interested in at the moment. Biomarkers is another one. So a significant amount of work going on with regards to biomarkers. That's either prevention, so a bit like the lateral flow test. You do something, take a saliva sample, nasal swab, and then that provides you with some kind of traffic light system and on the increased risk on that day based on biomarkers, or actually diagnosing somebody's had some kind of episode. You're not sure because maybe they're delayed or it's unclear, and then taking biomarkers and looking at the biomarkers which are associated with an episode of severe heel illness. So I think lots of work and research needs to be done, but I think that is picking up, and there's more and more high level evidence studies being done out there, which I think is really exciting.
Brilliant. So there you go. It's a bit of a call to arms for everyone in this full exercise medicine world to be looking into this more and studying patients when you do see it as well. I think it's really important. So, Ross, I've learned so much, and like you said, we could probably do a podcast on the assessment, on the the management, preventative measures. That it's been amazing to talk to someone with such a broad depth of knowledge in that area. Claire, have you got any more questions before we go?
No, I think I've taken so much from that. Thank you so much, Ross. I'm sure every listening will. I think my takeaway is cool them fast. I think there was always that little kind of thing of like, oh, can you cool somebody too fast? And it's like, sounds like just get them cool, bring that core temperature down. So there are lots of takeaways. I think it might be one I want to go back to listen to, and I hate listening to my own voice. So thank you so much, Ross.
No, thank you very much for inviting me. It's been an absolute pleasure. Thank you.
Thanks, Ross.